Hello, how everybody's doing? I'm Dr. Tompkins. So we're going to talk about some common foot and ankle injuries and pathology about the foot and ankle area, some of the things I see commonly in my clinics and everything. So we'll get started here. So probably one of the most common things I see in the ankle, definitely ankle sprains. Everybody on the weekends out playing sports or just walking on the curb and rolls their ankles. And I see a lot of these, during the week throughout the my clinics and everything. You always hear about two different types of ankle sprains. There's the low ankle sprain and there's the high ankle sprain. Low ankle sprains are the ones that kind of involve the ligaments kind of around the fibula bone that involves, this big ligament in the front, the kind of ligament that runs from the fibula down to the heel bone and the talus bone and the ligaments in the back. Make up the three of the big ligaments on the low ankle sprains. The most commonly injured ligament is this one in the front called the ATFL, which is pretty commonly injured, number one commonly injured ligament, and followed by the CFL, which is the second most commonly injured ligament in the ankle. So we'll see a lot of people will come in, swollen, ecchymotic, bruising everywhere, pretty tender to walk on. And then usually most of these people can get better without, anything surgical. Usually it's a typical rest, ice, compress, elevate, go into a lace up ankle brace. Sometimes I'll put patients in boots for these just to help with the swelling and pain control. Kind of the same thing in these high ankle sprains is something called the syndesmosis, which runs between your tibia bone and your fibula bone. And basically these involves the ligaments that attach these two bones together. These are the ones that these take a little bit longer to heal, of course, unfortunately, as they involve a little bit higher up. And, concerns with these, if there's any like instability between these two bones that can cause problems. And sometimes those do require surgery. So with ankle sprains, we don't have to get x-rays every time, but there's a few certain rules we follow for obtaining x-rays for ankle sprains or ankle pain in general. If you have pain over if you have acute injury, if you have pain over the bones on the inside or the outside of the ankle, if you have difficulty weight bearing, those are kind of what we call the Ottawa ankle rules, and those are kind of some indications to proceed with a x-ray of the ankle. This x-ray here does show some instability with the angle they've drawn there between the talus and the tibia bone, just indicating there's some instability of the lateral ankle. So when I'm, clinically, when I'm in there assessing the stability, I'm just looking to see how much tilt you have on the ankle, how much shuck you have, bringing the ankle forward. And treatment-wise, the vast majority of people don't require anything surgical for this. Most of the time early on, if you have this at home, you just want to rest it, put some ice on it, compress it with a compression wrap, elevate it up, and just kind of get off it for a couple of days. Get into a brace or a boot if you have one can be very helpful for a couple weeks. And the most important thing is doing some good physical therapy. A good functional rehab program is probably the most important thing for ankle sprains, just to kind of get back to normal. Unfortunately, these ligaments can take about 4 to 6 weeks to really kind of heal in and start feeling a lot better. So it can take some time, and the more severe the damage, the longer it can take. Now, for the patients that require surgery, usually I put them through a good physical therapy program to make sure they've done everything, and give it a couple months. If it's still not better and they have a lot of complaints of instability, then the biggest thing we talk about is ligament repair or reconstruction type surgery. But again, 90% of people will get better without anything surgical for an ankle sprain. And swelling is always the last thing that kind of can get better. That can sometimes take 6 to 12 months for swelling to improve even after an ankle injury, even if you're not having any pain. So definitely some common things you'll see with ankle sprains. The next thing we'll talk about is the peroneal tendon injuries. These are these tendons that wrap around the backside, on the back outside of your ankle, and kind of important in pulling your foot outwards. These are, can commonly be injured when you sprain your ankle. You have two big tendons that run back there that kind of, pull your ankle and foot outwards. You have your peroneal longus and peroneal brevis tendon. The peroneal brevis tendon is the tendon that wraps, the first tendon that wraps around the bone and then attaches kind of to the base of your that bump on the outside of your midfoot area, and then the longest tendon was the one that will actually wrap under the foot. And these are pretty important for both stability with ankles. They're the dynamic stabilizers, and they're also important in kind of pulling that foot outwards. So some important imaging, x-rays are important just to make sure you don't have a fracture or anything like that. Make sure you didn't break anything. For people that don't have a fracture and I'm concerned for a peroneal tendon injury, I'll usually put them in a boot for about 4 to 6 weeks. Have them work on some home therapy at first and just do the typical RICE treatment with the rest, ice, compress, and elevate. Most people will get better with this, and then people that are not getting better will order an MRI. And sometimes we'll see on MRI that the patients have a torn tendon. Now, usually the tendons don't tear completely, like longitudinally. They'll have, or they don't tear transversely. They'll kind of tear longitudinally within the tendon, and the tendon will still be intact, but you'll kind of have a longitudinal, call like a split tear in the tendon, which is pretty common. And a lot of times people with these split tears will get better. And a lot of times we'll find these incidentally when the patients are there for something else. So having a split tear in your peroneal tendon doesn't mean it has to be surgically treated, because there's a lot of times we'll find these incidentally when an MRI is done for something else. However, if it is symptomatic and we fail the outpatient, conservative type treatments, then the next step is, to do a surgery where we can go back there and open it up and find the tendons and fix the tendons and everything. Usually with suture, and a lot of times we have to do ligament repair for this, because this will also be associated with ligament or ligament injuries on the outside of the ankle if they have instability. So the next other common thing I'll see after kind of an ankle sprain, these are also associated with ankle sprains, that are what we call osteochondral lesions of the talus. So basically what happens is patients will roll their ankle, and they'll the tibia, which is the upper bone, and the talus, which is the lower bone, will kind of bang themselves together and cause this kind of like small little fracture that involves the cartilage that you can't see on an x-ray, but you can see better on an MRI. And then it'll cause a little fracture, fragment, and then some edema in the bone kind of surrounding that area. Now you have, you can get an osteochondral lesion anywhere. You can get on the inside of the ankle here, you can get on, or inside here, on the outside here. If you see a osteochondral lesion kind of more towards the inside portion of the ankle, that's usually more from an acute injury, like if you had an ankle sprain recently. If you see it more on the kind of like the inside on this side, on the medial side, or on this side of the ankle, it's always usually caused from kind of overuse or repetitive trauma throughout time. It's more of a chronic injury. Again, these are another thing that you can see have incidentally found on MRI, as patients will come in and complaining about something else, and then you'll go in there and they'll have an osteochondral lesion. Then then it's kind of up to me to figure out if that's causing the pain or something else that is causing the pain. But these are pretty common lesions. CT scans can also be done if you're concerned for a larger fracture fragment. Again, treatment, for patients I see early on, I'll put them in a cast for 6 weeks to give a complete rest, to see if this will get better, followed by, some extensive physical therapy and everything. And for the most part, people will get better from that perspective. Sometimes you can do an injection if patients don't want to proceed with surgery, to see if that will help. That will also help to determine if the pain's really coming from inside the joint or outside the joint by doing like an intra-articular injection. And then, for surgery, there's, a whole host of surgeries that can be done for this, from just scope, putting a scope in the ankle and kind of cleaning up the area. And then we do something called a microfracture if the lesion's small enough, where you go in and poke a bunch of holes in the talus bone and try to hope to grow new cartilage. Other options for bigger lesions is there's companies out there that have like cartilage that you can put in there and kind of glue it in place, and then your body will help form cartilage there. And then if the lesions are really big, then you have to talk about taking like cartilage from your knee and transplanting it down into your talus bone, and then having to do some sort of, osteotomies of the fibula or the medial mal, where you have to swing these bones out of the way to access them, which is definitely a lot bigger surgery. But for the most part, surgery for this is usually scoping the ankle. If they fail outpatient treatment, is kind of putting a bunch of poke holes in that bone area after you clean out the area to help maybe get some scar cartilage to kind of fill in there and see if that can improve the pain over time. Next thing we'll talk about, I see this a lot in my clinic, probably, 5, 6, 8 times a day, new patients coming in with complaints of pain of the back of the ankle. There's two most common locations, either they'll come in complaining of pain over the Achilles tendon, or they'll have complaining of pain right where the Achilles tendon inserts on the bone over the heel bone. So those you would call it either insertional Achilles tendonitis or non-insertional Achilles tendonitis. So in these pictures, you have a patient will come in, will have a big bump on the back of their heel like this. They'll have some swelling, be pretty tender right there on the back of the heel. You'll get an x-ray, and then all of a sudden you'll see this big giant bone spur kind of on the back of the heel. And you'll see this little bump up top, which we call like a Haglund's deformity. There's a special name for that little bump. And then the tendon will kind of attach right all in that area. And then the tendon will also be inflamed. And sometimes I also see little calcifications in the tendon, which also just indicates some degenerative changes in the tendon and everything. And this is all called insertional Achilles tendonitis. So extra imaging I'll do the x-rays to look for bone spurs. This patient even has a heel spur on the bottom, and also a bone spur on the back, but they usually have pain right in the back of the heel. And then I usually, treatment wise for these patients, this pain is pretty bad, we'll put them in a boot with a heel lift to kind of help elevate their heel up and offload the stress in this area. This is a high stress area. And then if you have a decreased flexibility, they can lead to increasing stress. And then, usually I'll put them in a boot with the heel lift for about 4 to 6 weeks to see if we can get this to rest and kind of calm down the inflammation. Now, it's not going to take away the bone spur. That will always be there unless it's surgically removed, but it can hopefully take away the inflammation to improve the symptoms. And then I always tell, patients working on icing this a couple times a day, taking some like Motrin or Advil or Aleve around the clock can be beneficial. And then usually about 80%, 75, 80% of my patients will feel pretty good after about 4 to 6 weeks in a boot. And if they're feeling pretty good, that's when we move on to physical therapy, because as they feel better, physical therapy is more effective. If I send patients to therapy too soon, therapy will just make it worse and they won't be happy with it. So physical therapy after a good amount of rest can be pretty helpful. And also you can move that little heel lift into the shoe, which can also be pretty helpful. And then physical therapy works on a strengthening program, works on flexibility program, which are important. Now for the patients that don't get any better, then I send them for an MRI to really look at that tendon and for preoperative planning. And the surgical treatment for this is what we do is we actually go in right on the back side of the heel and ankle area, and we kind of what we do is we end up splitting that tendon in half, and we have to peel it off the heel bone to be able to access that spur. And then we just take it, and then after we access the spur, we are able to kind of cut that spur off and that the Haglund's deformity, and then contour the back of the heel, and then we clean up the tendon, and then we reattach everything with a bunch of bone anchors back down. And for the most part, people do pretty well with this. 90+% people do pretty well that are having pain even after non-surgical treatment. And then we have, the non-insertional tendonitis. That's where we, having more pain, not on the heel, but more kind of up the leg, right over the Achilles tendon. Patients will come in complaining of really thickened and swollen and painful, hurts to kind of push off and walk, usually caused by overuse type injuries. And then usually we get an x-ray, and really doesn't show anything like any of the heel spurs that we usually see. And then usually we get an MRI to look for thickening of the tendon, looking for any sort of tears inside the tendon, any sort of swelling inside the tendon. But usually the mainstay of treatment here, we try to really hit it hard with physical therapy. We can still do the boot with the heel lift for this, kind of rest it, ice it, take some Motrin or Advil. But the most important thing after we get it to feel a lot better with that is to get into physical therapy to work on strengthening the tendon, work on a good flexibility program. The best way to strengthen an Achilles tendon is called eccentric strengthening. And then there's a specific program for that. Basically, what you're trying to do with eccentric strengthening is trying to strengthen your tendon when it's lengthening. So it's kind of like doing like a negative. If we're in the gym, it's kind of like doing a negative in the gym, but you're doing it for your Achilles tendon. Now, for people that kind of fail all that stuff, you can do a surgery, where you go in and you can debride up the Achilles tendon if it's painful, but I don't think this procedure works as well as the insertional Achilles tendonitis patients, because you're really just going in there, just trying to take out soft tissue that, might not look normal. And then other options for this is you can take out the disease portion and just do a big reconstruction with like a graft, or might have to transfer your big toe tendon to your heel to see if that will also help with the pain and discomfort and everything. But usually this is treated non-surgically, and a good flexibility program and strengthening program is pretty helpful for this. The next thing I see a lot of is ankle fractures. Usually you'll know if you have an ankle fracture, especially if it's a displaced ankle fracture. If your ankle looks pretty deformed, you probably should be seen and checked out to and had an x-ray, especially if you can't put weight on it. You probably should have an x-ray done. Now, the most common ankle fracture I see are, the ankle fracture right on the outside portion of the ankle called the lateral malleolus fracture. I see a lot of those isolated. Some of them need surgery, some don't. It all depends on how unstable they are in clinic when you're assessing them under x-ray. This is an unstable bimalleolic where it involves the lateral malleolus. Then you have medial malleolus fractures where it involves the medial malleolus over here, and then your posterior malleolus fractures kind of will involve in the back of the ankle. Not as common, and they're very uncommon in isolated situations. Usually you'll see a lot of them will broken all at the same time that you have to fix. So this is we call it a bimal, where it involves the lateral side and the medial side, and then this is definitely an unstable fracture or some displacement, so definitely requires some surgical fixation. So typical x-rays, and then sometimes you need CAT scans if you really need to look at the ankle for any sort of like significant displacement, or looking for fractures that go into the joint and see if there's any displacement in the joint, because the goal is to try to have a good reduced joint to hopefully minimize the risk of arthritis in the future. That's always the biggest risk of these ankle fractures, is patients will develop arthritis in the future, and the goal is to make sure that the ankle joint is aligned pretty well, so that hopefully to minimize the risk of arthritis. So treatment, splints and casts early on. If it's it's determined to be non-surgical, then we splints and casts, and usually off of them for 4 to 6 weeks, and then followed by a boot. Here's a kind of progression of the ankle fractures here. A looks like there's this is a non-displaced ankle fracture, nothing surgical. B was just a lateral malleolus fracture, it was probably displaced, so they ended up fixing it. C was a bimalleolar fracture where it involved both sides of the ankle, and then you can see D is kind of the worst of them all, where it involved that plate over the tibia is kind of the big vertical plate, so it involves the posterior mal. So they broke all 3 areas of the ankle. And the more severe your fracture, the more likely you get arthritis in the future. The less severe, the less likely you get arthritis in the future. But it's usually surgery is determined, in the clinic, and you're looking for ankle stability versus instability to see if there's any need for surgery or not. And, and then the next thing we'll talk about, plantar fasciitis. I think probably a lot of people have had this. I know it's extremely common. Probably definitely the most common cause of heel pain on the bottom of the heel in patients. Usually cause of just chronic overuse, where patients will get these little micro tears of the fibers on the bottom of their heel in this plantar fascia, which is a big band of tissue that runs from your heel bone all the way to the tendons in the front of your foot, provides support of the arch. Usually x-rays are obtained just to make sure we don't see like a heel bone like stress fracture, which can be seen sometimes. People can get MRIs, but usually save that for people that are not getting better with the conservative treatments. But MRIs can look for inflammation, look for stress fractures, look for swelling in the bones if there's bones concern. But the most important thing for this is 90% of people will get better with just doing home remedy type stuff. And sometimes this plantar fasciitis can take about 6 to 12 months to burn itself out. So it's one of those things that takes a while. And I tell patients if they're 50% better after 2 months, they're on the right track for getting better. The most important way to the treatment is you can get some over-the-counter cushioned heel cup inserts can be helpful. Icing this a couple times a day, taking some sort of anti-inflammatory, trying to modify your activities to do a little more lower impact activities. Doing some home stretching is the most important. So working on specific stretches, working on calf stretches, and there's a specific stretch called the plantar fascia stretch, which is on the next slide, where you basically pull your toes back and try and stretch out the whole bottom of your foot. As you can see, this guy's plantar fascia is really tense and tight when he pulls those toes back, and doing that 3 or 4 times a day, for a set of 10 and hold it for 30 seconds. Each repetition can be extremely helpful. And then, so that's probably the most important stretch they've done the medical studies on that can really work on stretching out the foot. This is another picture of the same thing. And this is a girl, work on stretching her calf muscle. The most important thing is keeping your knee straight when you stretch that calf muscle. And then this is something called a pro stretch, which is actually a little apparatus patients can buy on Amazon or whatever, and can I will also work on stretching the toes and the calf, and it seems to be helpful. For patients that don't get better with the home remedy stuff, there's a physical therapy program for this called ASTIM protocol, where patients can go there. They work on like a deep tissue massage and scraping technique to try to incite an inflammatory response in the foot, which will help with healing. Injections, there's steroid injections that can be done for this, but with steroid injections, there's about a 10% rupture rate with steroid injections, and they can cause, it can be painful injections, but it can be helpful in the long run. And there's surgery for this. We try to avoid it. The goal is to fail at least 9 to 12 months of non-surgical management before you consider surgery, this is only about 75% effective with the surgery, where you go in and release the plantar fascia by surgically stretching it out. But most patients will get better with the non-surgical home remedy management, and it can be pretty helpful. So I think that's the top 5 things I see in my clinic is pretty common, and everything, if any.
Thank you, Dr. Tompkins.